and if you are able, and we will Helen will take it away in just a moment. And Helen, you can take it away when you're ready.
Hi, everyone. Good afternoon. I'm Helen Belanca. I'm the chair of the Universal Health Plan Governance Board. And unfortunately, Debbie Diaz, who's the chair of this committee, is out on medical leave. So we are patching it together, and I'll be temporarily chairing this meeting while she's out. So thank you all for your patience. It's been a little bit of a scramble with the staff to put this together, but we'll proceed. So quickly, do we need to do a tech check, Katie?
Quick reminder for everyone. Just remember that we do have members of the public joining us today. They're just not able to connect their audio or their camera. So if you are able to, please keep your camera on so we can know that you're a committee member. If you're not able to, though, that's perfectly understandable. And then just please remember to select raise hand if you would like to speak, and Helen or a member of staff will call on you for you to share your comments. Other than that, if you run into any tech issues, you know the email to get a hold of me, and please do. So that's all for me, Helen. Oh, I guess I can go right into roll call.
Yes, please.
Perfect. Okay. So when I call your name, please just say, let us know that you are here, starting with Helen Belanca.
Here.
Cheryl Ramirez.
Here.
Chunwei Chi.
Here.
Dr. Hemmings.
Here.
Angela Mikulak.
Here.
Tony Germain.
Present.
Betsy Boyd Flynn.
Here.
Brian Frank. Okay, not seeing Brian yet. Eve Gray.
Here.
Gabriel and Dean.
Hello.
Jim McGee. And
all right, here.
oh,
I was on mute.
Thanks, Jim. Jamie Osborne.
Here.
Julianne Horner.
Here.
Max Kaiser.
Here.
Mike Durbin.
Here.
Peter Addy.
Here.
Peter Merritt.
Here.
Rob Facette.
Here.
And Tosh Rahman.
Here.
Great. Thank you all very much.
Excellent. So quick agenda review. We're going to go over a little bit of the feedback that we've gotten since the last meeting. And then we had decided at the end of that meeting that we weren't quite done with a benefits comparison between PEB and OEB. We had gotten a general agreement from this committee that we'd like to stick with the model of PEB benefits for the plan, but there are some little bit deeper questions around the differences between the Oregon Health Plan and PEB that we needed to get into a little bit more today. So we'll be doing that. We have a proposal for consideration, just one of many possible solutions to that discrepancy that we'd like this committee to consider, and we'll be breaking out into small groups to consider that. And then we'll just cover next meeting topics and any reflections and feedback. And then we'll have a little bit of time at the end for a public comment. So just as a reminder, we are very much in the early stages still of working through this plan design. As the committee members will recall, we have a separate committee doing finance and revenue, and they are currently working on a financial structure for the plan. And at some point, the financial structure and the plan design will have to be reconciled, obviously, because we're going to see what the revenue possibilities are, and we're going to have to align that with the benefits we want to offer. But while we're waiting for them to come up with a financial structure, we are working toward developing a benefit plan and prioritizing the benefits on that plan, so that if revenue limits what we can offer, we have a sense of what we are able and willing to cover and what would be lower on the priority list. We also need to talk about eligibility, which will be our next meeting. And then there'll be some questions around workforce and how providers would be paid in the new plan. That's part of our role as well. And as part of that, as you all are aware, I'm sure, comes the question of quality assurance and how we use quality currently. Quality is somehow bound up with payments in some instances. And so we need to think through how a quality system would work in this new plan. And then the assess and align portion of our work is when we would get together with finance and revenue and try and gel what they're doing with what we're doing. And then we would be presenting recommendations to the board. We are in January right now, so we're in our second benefits discussion. You can see on this list here that we're hoping to talk about eligibility next month and then start getting into provider reimbursement, cost containment and cost sharing, and then workforce. And then we have a month there that's free in case any of those topics need to spill over. But it's still a pretty aggressive timeline with a lot to cover. So we'll do our best to make that happen. I'll hand it over to Morgan at this point to review some feedback we got since our last meeting.
Great, thanks, Helen. And this is just a summary of the last meeting and major takeaways. So as Helen mentioned, we heard from the committee that there was a general consensus to endorse or agree with the task force recommendations for the Universal Health Plan to cover what was referred to during the meeting as PEB Plus, with no premiums, no cost sharing, and including vision and dental. As Helen mentioned, there was a request for more information on PEB and OEB coverage. There was discussion and more information around health-related social needs, substance use treatment, mental health treatment, long-term services and supports, fertility, vision, dental, complementary medicine, weight management, peer-delivered services. And in this list, as we were looking at it, non-emergent medical transportation, and we also included information in EPSDT, which is early screening. Yep, I knew I was, as soon as I said the acronym, I wasn't going to.
Screening and diagnostic.
Thank you, Laurel.
Yeah.
I had written it all over the slide, and then as soon as I was on point, I couldn't remember it. So next slide, please. In addition, we heard that there was need to have future conversations on carceral benefits, which will be included in the eligibility discussion, a kind of dedicated discussion on which levers are being moved in this conversation, process for determining benefits moving forward, and prescription drug coverage. So we've captured those. So we just wanted to let the committee know we heard these were areas where there's more kind of a more intentional focus in a future agenda meeting, and we'll be working to build that into the future meeting plans. Back to you, Helen. Helen, if you're on mute, we can't hear, or we can't hear you.
I apologize. Yes, I was on mute. Sorry. So when we break, so we were going to do the HMA is going to do the benefit follow-up at this point, right?
Yep.
Okay.
And before we turn it over to next slide, please, Katie. So one of the requests from the committee was to have a preview of the discussion questions before going into the presentation. So here are the discussion questions that the small group discussions will be focused around. This was also pulled out as a separate handout for in the meeting materials with the proposal, so you have that. So I just wanted to flag that for the committee so that you would be able to think about what those future discussion questions were going to be as you hear the presentation. So next slide, please. So in your meeting materials, you have a table with OHP, PEB, and PEB Plus. And we just wanted to pause for a moment, and Anya is here to answer any questions, if there are any questions about that table. And with that, I will turn it over to, well, I'll pause there to see if there are any questions.
I think Lou had a question.
Thank you, Anya. Lou actually is a member of the public.
Oh,
So, yes. So Lou, thank you so much for your hand raised. But since you are signed up for public comment, feel free to save that for the end during your public comment portion. Thank you, Lou.
okay. So yes, in your pre-meeting materials, you received this benefits table. This had been produced for the task force, and we tried to update it with the most recent information about just the Oregon Health Plan and PEB. In the header, you'll see that it says PEB cost sharing figures shown are for the least expensive plan for full-time employees, and that's my mistake. I misunderstood how the previous task force had chosen this plan. This is actually the Providence Choice Plan, I believe it's called, and it was chosen because it was the most comprehensive and statewide plan with fewer network restrictions than many of the other plans. And so it was, rather than being the least expensive, it was thought to be most like what you might be striving for in terms of PEB plus. So just wanted to point that out. I'll point out what the columns and rows are, but I won't go through in detail. And as Morgan said, if you have any questions, feel free to pipe in. So in column A, you have both a general title of the area or category of benefits, and then a general description. In column B, you have what does the Oregon Health Plan or Medicaid cover? And with what restrictions. So if it just says covered, then you can assume there aren't any major restrictions on that. In some cases, there may be a requirement for prior authorization. I didn't go through and note that everywhere. I just noted where there were major restrictions, or like in the example of transplant services. Yes, it's a covered service, but you have to go through not just sort of a prior authorization, but a fairly rigorous clinical test of whether you qualify for that benefit. Column C is the PEV Providence Choice benefit level. And you can see mostly what you see there is the same things are covered, but there's cost sharing. And so tried to lay out what the cost sharing levels were for each category of service. And as you get farther down the list, you'll see that actually, as Morgan noted, there are some categories of services that are covered in Medicaid, but not covered at all in PEB. So on the last page in particular, you'll see that non-emergent medical transportation, services for people who are incarcerated, health-related social needs, and long-term services and supports are covered to some degree in Medicaid, but not covered in PEB. And so that'll be some of our discussion today, is how do you want to treat those? And then column D is PEB plus recommendation based on your conversations to date, which largely sort of go along the Medicaid lines, Oregon Health Plan lines. So saying it should be covered, but there shouldn't be cost sharing to the level that there is in PEB. And so that's the general summary. And does anybody have any questions about it? Tashreeq.
Hey, so I just wanted to clarify something, and it's probably for my clarification. So the Oregon statute 751 kind of tells us that we need to protect individuals from the financial consequences of ill health. So cost sharing is a financial consequence. In my understanding, when we talk about cost sharing, there shouldn't be that concept of cost sharing because it prevents people from seeking care. And the same thing about PEP Plus, when we talk about networks, there shouldn't be any concept of network. Any provider, any Oregonian can seek any provider as long as they're licensed in the state of Oregon. So I just want to make sure those things are clarified before we look into this PEP Plus, knowing that when we talk about cost sharing and networks, those shouldn't be in our thought process.
Yes, I believe that's legitimate to assume in the PEB Plus conversation that you're talking about the covered benefits being of the breadth of at least the PEB plan, and in some cases, in addition, of the breadth of the Oregon Health Plan, with no cost sharing and with no network restrictions. So I think that those are the basics of our assumptions. But I think part of the point of today's conversation is to make sure that we're all solid on that. Helen.
Yeah, and Tasha, I think what you're saying is totally true. We have certain values and principles that we've been asked to adhere to from the legislation. You're right. And certainly the idea of networks, would not be consistent with that, and the idea of cost sharing would not be consistent with that. However, there will be some financial realities that we have to address. And so that is part of what the small group will be discussing is to what extent, if we don't want any cost sharing at all, to what extent then do we pull certain benefits out and have people purchase supplemental insurance for those? It won't be financially feasible to cover all benefits for all people. It just will become prohibitive. And so we have to decide, we either pull some benefits out or we have some sort of cost sharing. And while it doesn't adhere to the principles, our charge is to come up with the most feasible plan we can, given the financial limitations that we may face. And so our job is to recommend to the legislature a certain plan. And if we could design 2 or 3 plans and say, if we had no cost sharing at all, here's what it would look like. And it might be prohibitively expensive in terms of the revenue required. Or you could do this alternative plan and remove these benefits or add this cost sharing. And this is what it would look like. And ultimately it would be up to the legislature to decide. So we do absolutely want to keep those values in mind and in place. But I think we're going to bump up against some hard truths when it comes to the cost of providing that for every citizen in Oregon, every resident of Oregon.
Yeah, and that was last time, I talked a lot about actuarial value, and that's just sort of a balancing act in terms of who pays the cost. Is it the consumer or is it the payer? And yeah, I mean, you can load all of the costs on the payer, but then your bill for doing that is going to be what it is. It's not going to change the size of the bill. It just changes how you divide it up. So hopefully, I'm not sure how well I got that across last time, but that was what I was intending to convey. Antonio.
Yeah, thanks so much for your work on this, Wallach. Appreciate this, putting this across this grid and everything. There are a few things, I think, some nuances with respect to your comment to the actuary value. What we're building is a straw person idea as far as what we want included, and then that goes to the actuaries and put in place. The difference I think the distinction make in this effort is that the payer is all of us, right? So we're putting it into a pool, right? So it is a little bit of a distinction there. And I think that those tough decisions will come after the fact that we see some of the data with regard to when we put through these benefits that we propose, then we make the decisions on the backside as far as what do we need to limit is similar to what we're familiar in Oregon with the OHP prioritized list. And so thinking of that So I think be constructive for our conversation, one thing I would draw out is under dental, a really important feature that does have some differences between these. And some of those, I think, listing out those with more specificity would be helpful, that when we submit for that financial review and that actuary evaluation, we need to state what, between these and what we're going to vote on as far as what those are. I would also just call out as far as the vision, it's listed on some of those under OHP. And so if we're going to make a call on those, that would be helpful to see what those look like. When I was looked through, I think those were the main ones. And then the others was the complementary medicine. There is some difference between that and what is covered and what is not. I think just being more specific on those so that when we come to a vote, that would be helpful to see.
Yeah, I noted that in my review that there's particularly on the dental, well, yeah, on both dental and vision, there's some kind of interesting, odd rules that apply depending on which plan you're in. And these are the areas where actually Medicaid is a little bit more restrictive than they tend to be in other places. So, and I should have noted that last time I presented, we talked about PEB having dental and vision as separate benefits. They're administered separately, but they're available to public employees. So we've, at this point, just folded in so as not to confuse people. Jim. Oh, Jim, you're still muted, I think. There you go.
Yeah, although generally I support the provision for no cost sharing, I would like to make some maybe qualifications to that, specifically with regard to vision and possibly hearing aids. Our plan, the plan that I administer, just implemented because of language in the collective bargaining agreement, it said eyeglasses will be made at no cost. And they took that very literally, and the carriers had never, ever administered a vision plan with no cost. And one of the things that I have said to members in other situations is our vision plan pays for you to see good, not look good. and there's a lot of people who want to look at a vision plan as something to look good. So I think that may be an exception to the cost sharing rule. I'm less clear on hearing aids because I'm not sure to what extent some of the more expensive hearing aids are wants or needs. But there may be a minimum level at which there is no cost sharing, but above that, there may be some cost sharing might be appropriate.
And Medicare might be a better model for that, since that's much more of an issue in the over 65 population. But so I could look at what the Medicare restrictions or rules around hearing aids are. Eve.
Thank you. I think it would be helpful maybe in a future meeting to get some more information about other countries in particular who have single payer systems, universal healthcare access, and what are they doing to control costs? I personally am more familiar with systems of utilization management than cost sharing in these models, but I also don't know the world of possibilities that are out there. And so I think about the National Health Service in England or Australia and New Zealand have very similar agencies that are monitoring evidence, that are making determinations based on evidence about what will be covered and in what quantity and what the maximum amounts will be. And that's kind of an ongoing basis as evidence develops. I think it's more that I agree with eyeglasses and hearing aids that at some point we're going to have some maximum amount that the plan would cover. And I think about that with some things like PT visits. How many visits, if someone feels that they're getting a benefit from PT, are we paying for weekly visits indefinitely or twice weekly visits indefinitely? Or are we putting some limitation on that? And what are the other even surgeries and prior authorization requirements, which I did see in the statute, prior authorization was listed as something that should be taken into consideration when approving a service. So I just think it might be hard for actuaries to go through and cost this plan if we don't have some sense of, is there going to be any maximum to the utilization? Because I don't know that we have a model to look at that would say, what would that maximum top out at if we didn't have controls in place? So I think just a little more conversation about that on the front end before the financial analysis might help us get a better vision of what our proposed plan really costs.
Yep, very good point. Yeah, I think in other countries, what you'll see is very broad coverage. And I'm making a gross generalization here, but if you think about like the UK and Canada, very broad coverage. And mostly what they do is restrict payments to providers and supply. So you're covered, but it might take you longer than in the US to get access to something like an MRI. But we can look into that in more detail and give you some touchstones on that. Tashreeq.
Yeah, on the same topic, I think part of the conversation should also will focus on cost containment strategies. And even thinking about revamping our payment model, right? Like right now we have a fee for service, and it may not be the best, it may not produce the best value, right? So we may have to consider what would be an optimal or something that replaces it, but also adds value to patient care.
Yeah.
And similarly, when we talk about, there are avenues to save for savings, and that can add more services that we are trying to add to the program. So I think those are the conversations we probably need to have to really justify what services we are adding to the program.
Thanks. Helen?
I just wanted to invite Chunwei. We have a international expert on other health systems.
Oh, good. Yes.
He is here, and he helped actually build the single payer plan in Taiwan. And I wondered if you wanted to weigh in on how other countries manage the costs and benefits in this kind of situation.
Yes, no, I didn't build Taiwan's system. I only contribute a little bit of that. I think each country deal with that differently. The core issue is how much the society is willing to support and how extensive of that support. And so this could vary significantly, and that resulted in different countries either require cost sharing or minimal cost sharing or no cost sharing. And Ellen, you mentioned earlier that to what extent and how generous our coverage will be is closely linked with finance. So that's eventually this committee will have to reconcile with the finance committee, and it will be a back and forth, because if this committee feel that we want to be more generous, then we need to negotiate with the finance committee. That means the finance committee will have to come up with the more generous financing plan. And so also, by the way, in terms of taxing or financing, it will involve not just individuals, but also employers who have been contributing to the private health insurance eventually will also contribute to the universal health plan. We haven't finalized that yet. We're still exploring that. And one important issue we discussed earlier in the board meeting is how we set priority. And priority setting is a very complex issue, but ultimately it's a value. priority setting is not a science, it's a value based, that how much and to what extent we as a society or Oregonian want to cover. And once we decide how much we want to cover, then the science kick in, meaning given the kind of condition, the disease, the treatment or diagnosis we want to treat, how can we plan that in the most cost-effective way? And again, that's just a quick general comment.
Thanks. Angela, I noted that you had your hand up. Did you want to say something, or was that a mistake?
Oh, no, thank you. It wasn't a mistake. I was just echoing, just wanting to understand what other countries are doing and echoing, I think what Eve Gray had said too around utilization, how we're in this very, access and supply is also such a limited resource. So yeah, just understanding how other countries are managing that, because yeah, I can see, oh my gosh, everyone has healthcare insurance, but we don't have enough providers, and then and then how that impacts. And then even as we say that everyone has health insurance, well, how do we make sure people go to primary care versus ending up in the hospital, or so they're in the ER. So I think how we design incentives around that.
Great, thanks. Robert.
Yeah, so I just wanted to ask and comment, I guess. The fact that we're putting forward a recommendation which will then enter like a negotiation with the revenue committee, as Chinwe mentioned, I think is an important framing, in that like we also want to start that negotiation from the place that of the things we actually want. So as these materials came out, there was the set of things that were already listed as recommendations, and then there's another set of things that were already separated out and categorized as, for listing priorities that we might want to add in something like this. So I guess my question is, like, are we presenting it to the revenue committee in that way? Like, these are the things we're actually asking for, and if you can do more, then these are some other priorities we want to include? Or are we including in the recommendations, like all of the recommendations we're serious about, plus the ones that are listed here as potential priorities for adding, sort of communicating that as the what is the starting target that we're asking of them, recognizing that even if we, that these are public meetings and so it's not secret information, but like, what is the actual starting place for the negotiation? Is it all of the things we're recommending from PEB already, plus these things we're being asked to prioritize, and saying, listen, fund this, and then tell us what questions you have. Because I think like I just don't want to negotiate us down before we even start that negotiation. Negotiate ourselves down.
Right. So that's a strategic question that I don't think I can answer. Maybe Helen, you want to take that on?
Yeah, so I mean, a little bit, that's kind of what I'm hoping that we will get into in our small groups today. It makes sense to start with the PEB benefits, because I believe it was Eve who said something earlier about, we need a utilization limit. Well, the reason to start with the PEB benefits is because somebody has worked all of that out, sort of what makes sense in terms of how many PT visits you have per year and what your vision benefit is. And we could just copy and paste that and start with that. But the decision, Robert, to get to your question, is we have Oregon Health Plan, which 1.4 million people in our state about are on right now and are covered by, and they're entitled to certain benefits that PEB doesn't cover. And they get those at no cost sharing, of course, because it's Oregon Health Plan. And so, they're expensive, and there's a fair number of them. And so, and then there are benefits that both PEB and PEB and OHP both cover, but PEB covers them with significant cost sharing. You'd have to pay a fair bit out of pocket in addition to what your insurance covers. And if you had OHP, it's completely covered. And so the problem that we're trying to solve today is that if we give everybody just a PEB level of benefits in the state, we are going to be removing really important health supports from the OHP population. And we don't want to do that, because another one of our priorities is not taking anything away from what we don't want people to have a worse plan than they have now. So we want the folks that currently qualify for OHP to still get those benefits, and you know, still have the model of PEB to go on. So then we have to make some decisions. One logical conclusion would be, why don't we just give everybody what's on OHP? You know, give everybody all the services and supports that OHP covers and cover them fully. That's financially not feasible, primarily because of the long-term care. So long-term nursing care support, Medicaid will pay for it if you qualify for income, but otherwise that's a very, very expensive, I mean, budget shattering benefit is to pay for nursing home services sort of indefinitely. You qualify for it by income, but that's just one example of several that we're going to get into. And so when we think about those other pieces that are outside of PEB or that are partially covered by PEB and fully covered by OHP, this committee needs to make a priority list of like, okay, there is no way we can cover all of them. It's not possible. So either we have to have a tiered system, or we have to kind of rank priority of like, we don't want any cost sharing at all. So we want to fully cover services. And if we have to stop at this level and these three bottom things aren't covered, then that's where we need to stop. You know, if we need to pull out dental and vision as supplementary insurance, if we need to pull out long-term care supplementary insurance, but it's not possible to cover all these benefits for every resident of Oregon. There's no way. And and we don't want to take stuff away. So either we have to come up with a tiered system or prioritize. So yes, it's a little bit of both. And long answer to your question, Robert. It's a little bit like, yes, ideally we want to cover all these services for everybody, but when we get to our financial limit, these are the things we'd be willing to pull out and either do as a cost sharing or as coverage under a supplementary plan that people could choose to purchase. And we want to know the rank order, like what things should definitely be in and what things would be willing to pull out or have some cost sharing with. Does that make sense?
That does make sense. I guess I thought one of the things that we were trying to figure out in consultation with the revenue group is that question of what's not possible.
Oh, of course.
Rather than just like dictating it as not possible or outside of the realm of imagination. Like I guess I don't know what we've already heard from them.
Nothing.
Revenue team that would say,
yeah,
that's not possible. And
right.
I guess I thought that was the conversation.
You know, and I wonder if we could, it's not necessarily about possible, it's more about feasible. So like if everybody would get a brand new income tax of 25% of their income, you could say that's not feasible, right? If you'd get a brand new income tax of 6%, maybe that is feasible. So it's a matter of how feasible the revenue's got to come from somewhere. And so it's just, we could ask them to, you know, calculate out covering everything for everybody and just see, just out of curiosity, how much that would come to. That's definitely a part of what we could do, but we also need to have some backup plans because we can already assume just back of the napkin estimates that there's no way that we could raise enough revenue to cover all of the services for every. I mean, part of why cost sharing exists is because it's just not possible to cover, you know, unlimited benefits for everyone. So we need to do both. We can ask them to price it out for everyone, but we
so
already know.
I guess the strategic point I was making then, and then I will be quiet, I promise, is just that like that we're having this discussion today about priorities, but that's like an internal discussion for when we get that information back from them. We've already sort of pre-discussed what things we're thinking about.
Exactly.
Cutting first. Like that makes sense to me as a strategy.
Yeah.
Okay.
We have a very short timeline. So the finance committee launched just like a month before we did. And as they're doing their work, we thought we would think through some of how we would prioritize things first, and we won't have any hard numbers. And then there's going to be that reconciliation, but we're doing it sort of parallel instead of sequential, only because this board has such a tight timeline. We have a very short amount of time to cover a lot of work. And so we're trying to just get through a couple of these key pieces of the plan and get a sense from the committee of how what we would do with this. And then, yes, there's going to be a lot of reconciliation sort of at the end. But we're trying to do it in parallel. and maybe that's not going to ultimately be successful, but that was kind of the idea, that we would get as good of a sense as we could without knowing a number and then try and reconcile it later.
All right, Antonio.
Yeah, thanks, Helen, for that. I think kind of in summary, kind of what I sense is that we lack that information and we're in a space of incomplete information. And it's this back and forth before a proposal, before decision-making occurs. And I worry, and what I hear from Robert is that the challenge presents itself in making those decisions before we get to where we ultimately want to be. And I just wonder about the proposal of determining a set of, I think PEP Plus was chosen for a good space and for some of the reasons as far as utilization management is going to have to occur. That's going to be a piece of this in prior authorizations. You can't have everything in the kitchen sink. But I think the cost sharing issue is still something that I think should be considered rather than making a decision that we're going to adopt all of those features, because that inherently is the problem that we're trying to overcome with all the affordability for people in the country right now, and particularly in our state. It is a tool that we know has been really effective for OHP members to be able to get the care they need. And that's based off of financial, what they can afford. I do think the term of long-term services was removed for a reason. And I think that, having some conversations, maybe something of a consideration is that, so we can't remove any of Medicaid requirements. Those are they are set in order for us to get a waiver, or for get any of that chunk of money, those have to be in. So that's pretty much a slam dunk. We maintain the integrity of all of those benefits, but then for the general public, or for everybody, you find the overlap. But maybe perhaps at that income bracket with which those individuals meet at 138% of the poverty level, they maintain the integrity of all those Medicaid benefits. But for the extent of the rest of the whole population of Oregon, everybody gets a PEB plus. And starting that as the straw man, I think might be maybe just a proposal to this group to think through that. Long-term services could be think of the same way, is that those that would meet because of income eligibility would have long-term services in that space. You maintain the integrity of that. So I don't know, that's just maybe a consideration for us as a starting point. And then when it goes to revenue and finance, coming back and saying, okay, now we have some hard decisions. Now we have to think about what are those things as far as further utilization management. I pains me to say that, but I think that there are some things we're going to have to make some decisions on. Anyway, I don't want to talk too much.
Yeah, Tony, you just quoted almost verbatim the slide that's at the end of this presentation, that's the proposal that we're offering to this committee. That's what we're calling the tiered plan, with people maintaining their benefits if they qualify for OHP, and then everybody else getting a version of PEB. But yes, let's let Anya go through her slides, and then we're going to get to the proposal, and we'll break out in small groups and kind of dig into this a little bit more.
Okay, so should I not take the hands that are up now?
If people feel like they need to make a comment now, like Anya's going to go through some of these differences in a little bit more detail so that we have a better sense of it. And then we'll put some proposals on the table and break out. So if you feel like your comment or your question is really relevant at this point, if you're willing to wait till we get a little deeper into this, that would be appreciated. But keep your hand up if you want to say something now.
Okay, looks like Jim still has his hand up.
Yeah, I think what's missing is a framework for helping us. First off, I agree with the person who says we don't want to negotiate with ourselves. But at the point at which we have to make decisions, what's missing is a framework for making those decisions. How do we decide who's eligible for the Oregon Health Plan and who's not? I mean, obviously that's in law, but there's still some value considerations in that, not just economic considerations. In deciding among these benefit categories, what are the high value benefits versus low value? I mean, we ought to rethink this concept of actuarial value in a way that it becomes useful for our decision-making process, because cost sharing is not useful for our decision-making process. But if we had some kind of concept of relative value, that would help us make decisions if we need to. That's all I have to say.
Thanks, Tim. All right, we will now go into specific comparisons. Again, the PEB comparison here is for the Providence statewide PPO, except where otherwise noted. And so we're going to go into looking at health-related social needs coverage, which is unique to OHP, EPSDT, also unique to OHP, non-emergent medical transportation, unique to OHP, and then categories that cut across are substance use treatment, mental health, fertility, vision, dental, complementary medicine, weight management, and peer-delivered services. I'm not sure, we'll have to get to that slide for me to remember. Long-term services and supports, as already noted, they're covered by both, in the sense that both will provide some coverage for SNF services. But when I get to that slide, I'll explain some of the differences between Medicaid and PEB, and some of the things that are unique to long-term services and supports that make it kind of a category unto itself when you're trying to calculate, is this something we can cover for the entire population? So next slide, please. And this, I think that one of the staff people is going to cover.
Yep, that's me, Anya.
Hi, Jessica.
Hi everyone. I'm Jessica Marino. I'm with the Oregon Health Authority, and yeah, Anya is going to talk about that long list. I just am going to talk to you all about health-related social needs, or HRSNs, which I know a lot of you are familiar with, so I'll just talk about this for a few minutes. But in a nutshell, HRSNs are certain services and supports that are available to eligible OHP members to help improve health and well-being. These services and supports fall into three key buckets: climate, housing, and nutrition. And I'll talk a little bit about each of those in slightly more depth. You'll see on this slide, outreach and engagement is also called out as a core component of the program, which is slightly different from the others, but I'll talk about that in a minute. So first, climate. The goal with these services is to help people stay safe and meet their health needs during extreme climate events. The benefit includes access to air conditioners, air filtration systems, portable heaters, mini fridges, things like that. And the rollout of this benefit began in March of 2024. Next is housing. The goal here being to help people stay in their current housing and to prevent homelessness. So this benefit includes rental assistance, utilities assistance, storage fee assistance, tenancy support services, and medically necessary home accessibility modifications, such as ramp installation. And the rollout of this benefit started in November of 2024. And third is nutrition. And the goal here is to support folks with health conditions that need nutrition support in order to improve health outcomes. And there's really two main benefits within this bucket. One is medically tailored meals for specific health conditions, and the second is nutrition education. And the rollout for nutrition started just this month, actually, so January of 2025. And like I mentioned, outreach and engagement is a little bit different. It's not exactly its own umbrella of services. Rather, it's a mechanism for identifying OHP members who may be eligible for HRSNs, and then linking these folks to those services, as well as other Medicaid and non-Medicaid benefits. So it's not only HRSN benefits. So this includes a long list of outreach and engagement strategies. For instance, helping members gather documents and other requirements for HRSN services. And the rollout for this began in March of 2024 as well. So HRSNs hit the scene for the very first time in Oregon under our most recent 1115 waiver, which was approved for October 2022 through September of 27. And this waiver sets Oregon up to receive a little over 1 billion in federal funds over the full waiver period. And of that 1 billion, about 119 million is being made available as grants for HRSN providers for things like infrastructure and capacity building. And then 904 million is made available for the HRSN services themselves. And then finally, just to kind of put this all in the context of this committee's work, HRSNs were not available when the task force on universal healthcare was convening, which is why there's no mention of them in the task force recommendations or the preliminary structure. And then finally, just to reiterate, HRSNs are not covered in PEB, they're only available to certain eligible OHP members.
Thank you, Jessica. Very helpful. So again, this is those are benefits that are available only in OHP right now. I will say that there's a ton of activity in the private payer sector around trying to convince private payers to pay for the same kinds of services, and a lot of vendors who are trying to figure out how do they sell referrals and connections for those services to private payers. So. And I think I'm doing this slide, right? Yeah. Okay. So next we'll talk about another benefit that's covered in OHP, but not in PEB. That's non-emergent medical transportation. This is a required benefit under federal law. It's required that Medicaid clients have the ability to get to and from their medical appointments for approved care. Sometimes they may need evidence from a physician or another practitioner to prove that they need the transportation. Most states contract out for this with some sort of a more Uber-like organization that offers drivers and cars to do this. But this is not something that I have ever heard of being covered in any other insurance plan. Anything else that the staff wanted to say about this? Okay. All right, if not, then I'll go on to EPSDT. If you can learn this acronym, you get extra points on the final exam. EPSDT is early and periodic screening diagnostic. I don't know why it's not diagnosis and treatment. These are services that are required under federal law for Medicaid beneficiaries who are under the age of 21. This was implemented in federal law during a period where there's a lot of expansion of the federal requirements and the federal, so there's categories of federal Medicaid benefits, and there's mandatory benefits, you must cover these, and there's optional benefits. You can, as a state, choose to cover these. During the 90s in particular, there was a big expansion of both of those categories of services. Some of that is no longer as relevant since the Affordable Care Act passed and the essential health benefits are mandated across all carriers, but this is a category like health-related social needs and non-emergent medical transportation that falls outside of those essential health benefits and is covered really only by Medicaid programs. But if you're a Medicaid program, you have to cover a range of services for children and adolescents that includes screenings to find out if they have any kind of physical, vision, hearing, dental, or developmental or lead-related problems, diagnostic services beyond that screening to say, is this really a problem? How advanced is it? That kind of thing. And then treatment. So you must provide this for people under 21 in the Medicaid program. Next slide. So here's something that's covered by both programs, but there are some significant differences in terms of the breadth of coverage. So both PEB and OHP cover inpatient and outpatient substance use disorder treatments with no cost sharing. Some versions of PEB require some cost sharing, but the plan that we looked at does not. But OHP goes beyond in the sense that they provide coverage for additional screenings and assessments, medication-assisted treatment, which oftentimes is very hard to access through private payers. So Medicaid has been a real leader in providing access to that, particularly for people who are coming out of prison and are at high risk of relapse from opioid addiction or other addictions. This has been a real important thing. Acupuncture, methadone, Suboxone, and similar medications, in-home services for independent living, wraparound services for families and children, and peer-delivered services, which are sort of a burgeoning area of seemingly very effective substance use disorder treatment. So there are some limitations on the availability of these services, but generally they go beyond what PEB covers. And I guess I'll keep on going to the end and then ask if people have questions. Okay, so then mental health generally, aside from substance use treatment, again, both PEB and OHP cover inpatient residential services with no cost sharing. For outpatient services, there's 15% coinsurance for PEB. So if you go for a counseling appointment, for example, you would pay 15% coinsurance, but you would not have to meet your deductible to avail yourself of that service. OHP has no cost sharing, which is true generally across the board because Medicaid is not allowed to have cost sharing. And OHP also covers, I put community mental health services in here. Truth is, you probably can access those through PEB as well. But those community mental health centers in a lot of states tend to be very Medicaid and uninsured focused. And so it's an access point that while PEB people covered by PEB may be able to get it, it's particularly supported by Medicaid, and generally community mental health centers have a strong relationship with Medicaid and provide a lot of services to Medicaid clientele. Care coordination, emergency services, evaluation, Medicaid management, and in some states under waivers, there's even things like we got a waiver in or a state plan amendment, I can't remember which it was, in Rhode Island to cover detox housing for people who were suffering from alcoholism. And other things like that that are very, it could be very state specific, could be very waiver specific, but allow for Medicaid to target services to people with living with mental illness who may be particularly high risk. And so really, really important stuff. Jim. You're muted.
Keep myself off mute, maybe. As the grandparent of a severely mentally ill person, the only time that he has ever thrived is in a group home situation. Is there any space in here for that kind of coverage?
So under Medicaid, that would generally fall under the category of long-term services and supports. So you get long-term services and supports under Medicaid for one of or a combination of reasons. You're elderly, you're low income, you're very limited in terms of your activities of daily living. Those three things will qualify you for going into a nursing home and possibly for getting home care. If you're younger and you have persistent mental illness or some other kind of persistent disability, then you can also qualify for either Medicare or Medicaid coverage in some circumstances to get at long-term services and supports that are more aimed at non-elderly, non-nursing home populations. So populations like kids who need residential care, people with major developmental disabilities who need long-term residential care. So those tend to be covered by Medicaid. It varies a lot, state to state, what the rules are around those and what the availability of services is. But they generally fall under the category of long-term services and supports, which means you not only need to be income eligible, but you also need to meet clinical criteria to be eligible for those services.
Thanks.
Yep. Next slide, please. Okay, and now we get to long-term services and supports. Before I get into the specifics, I would just say something that the previous questions raised in my mind, which is one of the things that's really specific to long-term services and supports and makes it kind of different from, aside from how payers treat it, what makes it different from other categories of services is that the substitute for not having a medical source for these services or a therapeutic source for these services is that your family takes care of you. And so one of the real conundrums around long-term services and supports, and one of the things that makes pricing long-term services and supports for the entire population both difficult and ultimately expensive, is that if you made these services available, a lot of people would get them, it would reduce stress on their family, get them outside, get these services outside the home in a new way. But the public program would be substituting for what is now family provided care. I am not saying that that's not a good idea because a lot of families are incredibly stressed out and stretched to take care of their elders, their kids with disabilities, their kids with severe and persistent mental illness, et cetera, et cetera, et cetera. But that's just a fact. It's not like if you don't get long-term services and supports, it's not the same as you don't have a primary care doctor. You know, there is kind of a backstop there that we've taken advantage of as a society. And other societies don't expect that families do that, or they at least provide some kind of respite for families at a minimum. And there are states that have, through Medicaid waivers, tried to provide respite services so that if a spouse or a parent is taking care of somebody who needs a really high level of in-home support, they at least get some relief so that they can continue providing that support to their loved one. But those programs are pretty few and far between, have not really proliferated very much. So having said all that, long-term services and supports, again, inpatient stays at skilled nursing facilities are covered. There's some big differences. PEB covers up to 100 days a year with no cost sharing. I assume that that's mostly for rehab services. So post-acute, you've been in a hospital, you need to go to a skilled nursing facility to rehab, they'll cover you for a period of time. That makes sense for kind of a working population, that would be the main concern. OHP, on the other hand, like all Medicaid programs, is kind of the payer of last resort for long-term services and support. So they cover anybody who qualifies, but it's hard to qualify and there's no cost sharing. So you qualify because you have a low income. You can't you are SNF level clinically identified, so you are in need of SNF level care. Usually that would be identified either when you're already in a nursing home and you've been you and your family have been paying for that service, or because you're coming out of a hospital and you are not clinically able to go home. So it's not a low bar, but once you're covered, there's no cost sharing. There are restrictions in terms of how many assets you can have. And usually this is, as I said, this is the backstop. So this is what kicks in when you've exhausted all your other resources and you need skilled nursing facility care for the rest of your life. And that's a lot of the people who live in our nursing homes. In terms of in-home services, both OHP and PEB cover this with no limits and no cost sharing. I was actually surprised. I think that's pretty generous, the PEB version of this. I don't think there's a lot of employer-based insurance that is that generous. And in terms of community-based services, PEB doesn't cover them. And again, OHP covers them with specific eligibility requirements. And again, this is really variable state to state. States have tried to get waivers to use community-based services as a way of keeping people out of skilled nursing facilities. But it's a challenging thing to do because under Medicaid, you kind of have to, if you say something is available, you either have to put a fence around it and say it's only available for X number of people, and then you control the cost of the program, or you say it's available to everybody and it becomes an incredibly expensive benefit. Next slide, please. Fertility services, this is, to be quite honest, something I'm less familiar with, but OHP doesn't cover it. PEB does cover it. You can see what all the restrictions are here, and I think Laurel, maybe if there's any questions on this, Laurel might be able to. I think she's our resident expert on what the restrictions are and what's allowed under this coverage. Next slide. Sorry, did I cut somebody off? Okay, next slide, please. Okay, here we are. Vision. This reflects, so again, PEB administers not mental health, vision and dental through separate contractors. And so you choose not only a medical plan, which we've reflected here as that PEB statewide Providence choice or whatever it's called, but also within the categories of vision and dental, you have a choice. So this reflects the PEB basic plan. And OHP covers with no cost sharing. You get a routine exam every 24 months, and only people who really need them or are children or pregnant adults are able to get glasses or contact lenses. So pretty restrictive benefit under Oregon Health Plan. PEB, you can see they have all these various cost sharings depending on what you're trying to do. But you can hear, this is a great example of where you can see kind of the cost sharing approach versus the utilization management approach. So OHP puts some rules around this benefit and says, and the reason they can do this is because it's an optional benefit under federal law. So they can actually impose more utilization restrictions. So you can see OHP takes the route of utilization restrictions because they can't impose cost sharing, and PEB imposes cost sharing in a bunch of different ways and some limits on services generally. Next slide. Dental, this reflects the Delta Dental PPO in-network option. I think there were like 4 or 5 different options, but this is, so OHP, again, kind of similar to Vision, you'll see that they have some limits in OHP based on how often or how many services you can get. And then PEB has a lot of different cost sharing restrictions or requirements. And I won't go into all of them, but that it's you can kind of really see that contrast between, okay, under OHP we can't impose cost sharing, so here's how we're going to control the use of services. And under PEB, they say you can have access to these services, but you're going to pay. Next slide. Complementary medicine, OHP covers chiropractic and acupuncture only for rehabilitation purposes. I don't know exactly how they define that. Only by licensed providers, no cost sharing. PEB also covers massage with some limits on the types and amount of services. And you can see some examples down below of what you need to pay for those services and where they put annual limits or co-insurance requirements on them. Next slide. Is there a next slide? I think there's a next slide.
Are you seeing, I have the weight management slide up.
It's not coming up for me. I'm sorry. It must be my, there it is. Okay, great. Jamie, you want to ask a question? Oh, Jamie disappeared from my screen.
I'm
Okay.
here.
There you are. Great. Thanks.
Thank you. Just on the previous slide with complementary services, there are limits imposed as well with the CCOs through in OHP as well. Like you can have a certain number of acupuncture visits, but you can't do PT and acupuncture at the same time. It has to be one service at a time and a limited number of visits in total. And so there are some other nuanced ways of limiting that, or in some ways.
Yeah, thanks. And that's a really good kind of overarching point. I did not look at how CCOs impose limits that might go beyond what is kind of listed on the OHP general benefit restrictions. So yeah, there may be other utilization management tools that CCOs use that of which I'm not aware. Was there another hand up? I thought there was, but. Okay, weight management. Who's our expert on this? Somebody else was going to talk about this, I think. If not, I'll just go into it. Both PEB and OHP cover bariatric surgery, but put limits on it. And again, you can see OHP is sort of the gatekeeper there is clinically appropriate. So presumably they have a medical director who says on a case-by-case basis, is this surgery really needed? I don't know what their clinical criteria are, but that's often used for things like bariatric surgery, organ transplants, cancer treatment, things that are really costly, tend to be subject to review by the Medicaid medical director, who makes a case-by-case determination of whether they're medically appropriate. OHP also covers weight loss medication for certain diagnoses. I think it's sort of similar to what Medicare just said they would cover, which is they would cover the GLPs for diabetes, but I don't know that for sure. And then PEB, you can see there's more cost sharing introduced to discourage frivolous bariatric surgery, if there is such a thing. And then they require prior auth for weight loss medications, but otherwise it's the same kind of thing for certain diagnoses. Next slide. Peer-delivered services. OHP covers peer recovery mentors for substance use disorder, doulas, and community health workers. All of these kind of extenders have been shown to be effective in avoiding the use of higher cost providers. And so kudos to Oregon for integrating that into your program. I assume that most of that would be under your waiver. And PEB covers doulas, but not the others. And just a note on peer recovery and community health workers, well, peer recovery, I'll say mostly. You know, the effect of the Affordable Care Act was to raise, as somebody, I think it was Jim noted, or Tony maybe, to raise eligibility to 138% of poverty, regardless of categorical eligibility. So in the past, you had to fit into a category. You were a pregnant woman, you were a child, you were a woman, a single woman with children. After the Affordable Care Act, it's anybody under 138% of poverty. A big effect of that has been to bring single men into Medicaid coverage, and particularly single men with substance use disorder. And so some of these peer recovery, medication-assisted treatment, et cetera, have been really relevant and important in the post-ACA era for Medicaid programs. Max.
Sorry, I'm slow on my hand. It's from the previous slide.
Oh,
OHP doesn't cover weight loss meds. There's some meds that have some overlapping diagnoses, but not for weight loss itself. And EPSDT is different too.
yeah, I wondered about that. Okay,
Yeah.
thank you. Thank you. And I welcome any corrections or edits on these slides, because this is me trying to figure out from afar, or the staff trying to figure out from afar what's covered, and it's not always really apparent. Okay, next slide. I think that this is Helen's slide, and so I'm going to hand it back to her to talk through it.
Great. Thank you so much, Anya, for going through that detail. So I kind of alluded to this earlier in our discussion, but I just wanted to kind of summarize on this slide kind of the list of benefits where in a lot of commercial plans and in PEB, the way that they mitigate overuse or inappropriate use is with cost sharing or limiting the benefit in some way. And these are services that are often fully covered, with the exception of infertility, by OHP, and the exception with the weight management drugs. So again, like I was saying before, you know, we're required under federal law to provide some of these benefits to our Medicaid population. We're not required to provide it for all. And there's going to be a limit at which, you know, that these are going to come into conflict in terms of what we can raise in terms of revenue. So when we have vision, dental, hearing, community mental health and care coordination, weight management, which is bariatric surgery and the weight management drugs, peer delivered services, long-term services and supports, which is like the skilled nursing, long-term services and supports, meaning in the in-home stuff, and then the long-term residential skilled nursing, non-emergency medical transport, infertility services, health-related social needs, and some of the complementary services, chiropractic care and acupuncture. These are kind of the list of services that we should think through in our small groups about if we were to prioritize these. If we can't cover, the ideal would be to cover all of them for everybody, right? That's a given. In the financial reality that we can't cover all of these for everyone, how would we prioritize them, or would we do a tiered system? Let's go to the next slide. I think I laid it out a little bit. So like one idea, as Tony was talking about earlier, you could just say, you could pull out some of the benefits and have them apply to only part of the population who would qualify for them based on income. So long-term residential care in a skilled nursing facility, non-emergency medical transportation, and health-related social needs seems sort of an obvious group to pull out. We have waivers for that population. We could continue to provide those services for the population that qualifies based on income, but not for the rest of the residents. So go ahead, next slide. So another option would be to prioritize the benefits in order, like make a prioritized order, like, you know, this first, the second, like order them in terms of priority and cover as many of them as possible in a miniature version of the OHP's current prioritized list. So full vision coverage for adults and children, full dental, full hearing, bariatric surgery and weight management drugs, extra supports for mental health and substance use treatment, infertility, doula care, chiropractic, acupuncture. You could just I just put those in a random, they're currently in a random list, and we could put those in an ordered list based on what we thought of as the priorities for coverage, and just kind of cover as many of them as we could based on our budget. Next slide. Okay, I thought there was one more, but let's go back then. So okay, so I had the questions slide got moved to the beginning of the presentation. But if we could scroll back to that question slide so that folks know what they're, okay, yes. So when we break out into our groups, Katie, can you help me right now? Like, where are we in terms of time?
Yes, on the agenda, we were going to break from 2:30 to 2:40.
Oh, okay, have a break, and then when we come back, do the breakout groups.
Yes, exactly.
Yeah, let's do okay, so we'll do a break from 2:25 to 2:35, and then when we come back, is it accurate, Katie, to say when we come back, we'll be automatically in our breakout groups? Is that right?
Pretty quickly, like once we all come back together from the break, I'll just need a minute or two just to get everybody out, and then yeah, we'll go right into groups, and we'll have 30 minutes in the small group sessions.
Cool. Okay, so then when you come back, we'll do a break right now, and then when you come back in in the small group, what we want you to discuss is these three questions. Number one, should we have a tiered benefit system, which is sort of what was just listed in that slide, in that first slide, which says, you know, basically everybody gets the exact same benefit, and we're going to just do that as much as possible. And then we're going to pull out the things that OHP folks currently qualify for, the non-emergency medical transportation, health-related needs, and just blanked on the third one.
ESTT.
Oh yeah, that's in there. So like, do we do a tiered system where, you know, if you qualify for income, you get a slightly enhanced version of our universal plan? That's one version. And then if we need to prioritize the 8 to 11 benefits that are in that list, how would you prioritize them, like sort of in a ranked order? Like, what are the most important things to make sure we cover? And if things have to get dropped off the list, which ones would get dropped? And then the question of, is it better to limit the benefits or introduce some sort of cost sharing? We got into this discussion earlier at this meeting. And so this is a chance to talk in a little bit more detail about that. Do people have questions about what we'll be doing in the breakout groups?
Yes, Jeannie.
Thank you. I just wanted to clarify the part B of question 1. If so, which are included? I thought you already answered that.
Well,
that all of the OHPs need to be included in that. So is that in addition to that, are there other services that we think should be included? Is that correct?
Exactly right. Should we, like, those three have to be in there? And then in addition to that, would you put anything else in there, or just leave it at that? So that was just a proposal to the proposal is to just leave it to those three. And sorry to make you keep going back and forth, but let's flip back to the proposal slide. Sorry, the proposal back up. That one. Oh, one more. Oh, long-term care. Long-term care, not, I forgot. Long-term care, so that's like, you would only qualify for long-term skilled nursing if you met the income requirements, non-emergency medical transportation, and the health-related social needs, which is an Oregon waiver. Those three would only be available to folks if they qualify based on income, and then everybody else would be on a plan. And then in addition to that, the next slide, if we can't cover all of these services here, and this has changed a little bit based on our discussion during this meeting. This has been a presentation by committee, apologies, so it's not totally consistent with what we just talked about, but vision, dental, hearing, weight management, infertility, doula, chiropractic care, so some peer delivered services and chiropractic care. What are the priorities in terms of what should we cover for everybody versus if something has to get dropped or pulled out as supplementary insurance, how would you rank order those? So those are the two questions.
And then Helen, Peter Merritt has a question as well.
Yeah, thanks. I wanted to suggest kind of an addition to question number 3 for the small group questions. And that was essentially just that it seems like it's not exactly called out here that we could also consider a cost sharing system that's based on a tiered system. So cost sharing only for people above a certain income or so on and so forth. So just want to call out that it's kind of like not necessarily an either or, but we could kind of do both.
Yes, exactly. That's a great point. Thank you. Anything else? So we'll take a break and come back at 2:35. 2:40. We're at 2:28.
Yeah, let's do 2:40.
Yeah, 2:40. Yeah, because we're at 2:28 now. Okay, we'll take a break. Come back at 2:40.
Okay, it's now 2:40. If everybody could just gather back, turn on your camera if you're able, and we will get started in just a moment. And Helen, I'll leave it up to you to start when you are ready. You're on mute still.
Start meaning, I thought we were going right to the small groups.
Okay, perfect. Yep. I just want to set up a couple things then. Members of the public, the committees are all going to be separated and they've already been just randomly selected to go into different groups. During this time, you are able to either go into the groups with them and you can choose which group you'd like to join, or you can stay in the main room until they're done. So with that, then I'm going to go ahead and put everybody into the groups and then we will reconvene in 30 minutes. So at 3:10.
And just a reminder for all of the small groups to decide on somebody to report out when we get back. So each group will share highlights from their discussion and the discussion questions. And also another reminder is that there is the proposal in the meeting materials that you can pull up if you need to see that while you're in your small group discussions. And 2 of the 3 discussion questions are included in that. The third one was a late breaking addition around cost sharing. So just make sure to talk about that as well. And we'll see you back in 30 minutes.
Great. Thank you, Morgan. There also will be a member of staff or from HMA in each group. So just a heads up. So I will go ahead and open those rooms now.
So for some reason, my speaker could not work in the session. Could you put me back into my session?
Yes,
And see if I can get it to work now. Thank you.
Yes, you were with Helen, right?
I think so, yeah.
Okay, yes, I will get you there right now.
Thank you.
It's giving me an error really quick. So Julianne, I'm gonna remove you from Helen's group, which means I'll have to put you into another group, and then I'm gonna move you back to Helen's group. Hopefully that will solve it.
Are we back in the big group?
Yes, we have everyone back.
That was a little abrupt. That was too short.
Zoom isn't very polite, is it?
Yeah.
Helen, from here, would you like me to call on groups to have the readouts, or do you want to take the lead on that?
Yeah, I can't see any groups. And I don't know how many there are.
We have 4 groups total. And we can just go ahead and start with Helen's group, the person that is going to do the readout from Helen's group.
Okay, I can do that. We had pretty general agreement about the idea of a tiered benefit system with specifically non-emergency medical transportation and health-related social needs being in that tier. We had somebody comment that the use of the term tiered is probably not ideal. It doesn't come across well to the public. So thinking of a different term for that, maybe like enhanced services or something like that, that'd be the basic plan and the enhanced plan with those. But non-emergency medical transportation and health-related social needs should be available only to those who would qualify based on income. And then similarly with long-term care, long-term residential skilled nursing care, we had agreement that that could be offered if you qualify for Medicaid as it is now, and then the rest of the population, that could be something pulled out for supplemental insurance, that people could have the option to purchase supplemental insurance or spend down their assets so that Medicaid would cover it, similar to the system now. We did have a request to examine that in more detail, and that's has come up more than once. The task force recommended that, so we need to consider having like some sort of subcommittee to investigate long-term care and the costs associated with that in the current insurance market. So making a note of that. We didn't get super far in terms of prioritizing the benefits, except to say that probably infertility and complementary care would be lower to the bottom. I need to investigate a little bit more about our law says that any licensed provider in the state should be covered under the Universal Health Plan, and we have licensed acupuncturists, licensed chiropractors, and they're all equally entitled to participate in the Universal Health Plan as our allopathic clinicians. And so we might need to investigate that further, the extent to which their services would need to be covered. Yeah, we didn't prioritize anything beyond that. And we didn't get to talk too much about the idea of limiting benefits or cost sharing. That question we didn't get to.
Thank you, Helen. All right, we can go ahead and move on to Morgan's group, and the person in Morgan's group that's going to do the readout.
Yeah, thank you. Well, we got it all solved, it's all fixed, so we can all go home now. It was really easy conversation. But I think we modeled a lot of what the chair's group shared. I think a few things that stood out is, thinking of process and strategy when we make tough decisions in this way. And I think that that's one thing that kind of stood out to us, is that, when we send this proposal of these benefits package to the actuary, it would be ideal and I think instructive to look at the broad set of benefits that we have in front of us, and then also give the strategy of what would be option 2 to start removing certain features of that. We had a long discussion about long-term care. That obviously is a very challenging scenario. One of the points made was that maintaining the integrity of the current structure of system based off of income eligibility would be a reasonable approach to that. I really appreciate actually that term enhanced services and thinking of it as that way. And supporting community members that have less means, and that is a structure that we use in the Medicaid population. I think that that's a great way. With regards to the ADA list of the benefits, I think we need more information, and that was it stood out to us as far as there are some tools and thinking of like dental coverage. Some of that I think it would be constructive to look at what that utilization as far as, you know, is that one pair of glasses in a year, 2 years, and using PEB benefits at this point be reasonable. You know, thinking of how many PT visits in a year, how many chiropractic visits and things like that, those may be tools levers that we can turn. We did discuss maybe as far as a tool to give feedback on that, is it's really hard in this setting to go through each of them and tier them, but maybe it might be constructive to send like a poll out to list those in order as a starting point to summarize the broad opinions of this group. And we didn't really also, I think, get to question number 3 for our group, so I won't comment on that just yet.
Any questions? Oh,
yeah,
go ahead.
Yeah, Tony, what was you said you had a long discussion about the long-term care. What was aside from it being covered for folks who would currently qualify for OHP, did you come to any other sense of what should happen there?
I think we just have had many experiences in the challenges of people having to sell assets to burn down their total wealth and income to meet eligibility for that. So that is what we were largely talking about, and there are a number of stories. But I think we did agree that that would be probably a larger piece to this puzzle, that we felt that if we had to tier, that would be one that would come up front.
Any other questions or comments for that group? Okay, perfect. So the next group, Jessica and Janine. Whoever was in Jessica and Janine's group that's going to speak. Now you can go.
Hello, I think that's me. So for question 1, I think there was general agreement that the 2-tier system made sense. So that the population that's currently eligible for those sort of Medicaid only benefits now don't lose it, even though we wanted to think like in the horizon of the program, getting the whole population included for all of those benefits. And in particular, we also touched on long-term care for all of the many of the reasons that Tony said. Just that, like, data wise, like there are anecdotes about how this impacts people, but the data also says, like, a huge number of medical bankruptcies are because we charged you all your money to get you eligible for Medicaid. Once you're eligible for Medicaid, that kicks in. So the long-term care is definitely, one that I hoped would be included in the vision for the horizon of the program, if not at the beginning, but that 2-tier to start with made sense. On question 2, there's a lively discussion where we ultimately decided to report out some that we thought were at the top of these 8 and that we thought would be at the bottom, and then everything else falls naturally in the middle. People were passionate about dental care. Some were particularly passionate about the doula care, for equity as well as other reasons. And vision sort of being near the top. The mental health additional supports, there was like a mixed feeling, but nobody thought it should be at the bottom. So some had it near the top and some more just in the middle. And that was mostly because of thinking of those as supplements to benefits that already did exist. So wanting to know a little bit more detail about what what is included in that list of supplemental or additional benefits that would be included, and not prioritize those that put it in the middle, didn't prioritize it at the top because of its sort of supplemental nature, where it's already getting a broad coverage in the rest of the benefit package. And that the infertility treatment and potentially the bariatric surgery coverage would be near the bottom of the 8, while recognizing that all of the 8 are good and we want them. For question 3, we didn't get too much time, but I would just put out there that limiting benefits is a form of cost sharing. It's just putting 100% cost sharing on anyone who doesn't qualify for the benefit, 100% copay, co-insurance. And so with that said, I would say that like having more benefits with lower cost sharing rather than just not having benefits at all is interesting and probably able to cover more people, but that's just my opinion because we didn't really talk about that. Inviting others from the group to comment.
I think the only thing else, Robert, was that we kind of left, I think, chiropractic and acupuncture, was it the middle, I think?
Yeah, by default in the middle. And there was some discussion around that about the I think it was, well, maybe someone can supplement me here, that these are helpful and useful, and there was some concern about the evidence basis for their being effective for everything or certain things. I would argue that billions of people use these types of services around the world and trust in their healing nature. So that's some amount of evidence, but not evidence in the way that we normally think of it.
Thank you, Rob. Any other questions or comments for Rob's group? Okay, we have one final group, which was Anya and Danielle's group. Take it away.
And Peter is reporting out for our group.
Oh, thank you. So great conversations hearing from the other groups. So what we were talking about, I think a really important thing is more like, what is the algorithm by which we are sorting these things rather than what is the final sort, because our population is going to change. The evidence base is going to change. So like, what's the thinking behind why we're sorting these things, I think is really key. So we also agreed a tiered benefit system. So those top 4 that were suggested, that those are income-based. As a personal aside, not the group thing, I would wonder if we could maybe raise the income limits for those. We don't have to have it the way that it currently is, perhaps now or in the future. But anyway, so a tiered system for those 4, yes. For the other 8, well, we split them up differently with the general idea. So again, like, what is our sorting algorithm? Primary prevention is the most important. So top of the list absolutely is extra supports for mental health and substance use treatment. It's going to save a ton of money. And then thinking about beginning of life, early prevention is key. So doula care, dental, vision, and hearing for children come before dental, vision, and hearing for adults. We decided to split bariatric surgery and other weight management treatments. And I think there was some back and forth about that. I think that a general idea of bariatric surgery maybe higher up than the other weight management treatments. Chiropractic care, acupuncture, and also sometimes included in that is massage therapy as well. It wasn't on this list, but it often is the kind of complementary alternative that's also kind of in the middle. I think it should be pretty high up there. Others in the group should be kind of lower, but it's a middle tier for sure. And we put weight management and then infertility treatments at the very bottom. So, so we split some things. So adult versus child. Oh, we split up bariatric and weight management. And then, and the other thing, I listed those as the same, dental, vision, and hearing, kind of as one group. But if we have to split those, if we have to sort within that group, dental first, and then probably vision, and then probably hearing. But I think more important is children before adults. But I think we could probably get both. Yeah, I think that's about it. Did I miss anything?
Good job, Peter. I think we did have a little discussion about sort of equity issues, which, when you're trying to apply or prioritize this list across all populations, there may be equity issues that don't really get revealed in that, some benefits have greater benefit for some populations.
Betsy?
I just wanted to say I really appreciate the construct of prioritizing that which is preventative and has the longest sort of tail in terms of benefit and prioritizing children. I think that's a helpful way to think about it, and appreciated the thoughtfulness around the fact that the evidence base will change over time. That's all. Just wanted to sort of compliment that.
Thank you, Betsy. Gabriel?
Yeah, Betsy, maybe I'm doubling down on your instinct there. I wanted to also recognize, one thing that Peter shared from his group was that they approached the ranking question by first questioning, what's the paradigm or the algorithm by which we're going to attempt to rank these things. And that's one thing I appreciated about the effort in developing the original Oregon Health Plan, or many decades ago, was that this is fundamentally a question about community values. And there were a lot of community meetings that took place to help rank order these different services. And that Peter's group identified that primary and prevention, that sort of framework was going to be one of the sort of ethos which they approached ranking these things is helpful. But whatever paradigm we use, just sort of thinking about things that way. I would be cautious about ranking things based purely on their efficacy, for example, because while some things may be very efficacious, fertility treatments may be very efficacious, it doesn't necessarily mean that they're something that our community values more than, for example, dental coverage. So thank you.
Thanks, Gabriel. Jim?
Yeah, it seems like some of the other groups had discussions similar to ours about long-term care and sort of reevaluating qualifications for that. And any discussion by whomever on that topic down the road should be done in the context of the collapse of the private long-term care insurance industry. Because it's just my own carrier, which was supposed to be one of the rocks, has stopped issuing new policies, and it's just disintegrating. So something needs to be done at a larger level than perhaps can be accommodated in the context of this group.
Jim, do you know anything about why that is?
So one of there's the two biggest reasons that I got were it's basically they're losing money, and they're losing money for two reasons. One, they always banked on people buying insurance and not keeping it, and people were buying insurance and keeping it and using it. And secondly, after 2008, this prolonged period of low interest rates where they couldn't invest their reserves to make money. Those are the two reasons that I have heard. There's probably other reasons too, but
Thanks, Jim. Anya, did you want to add something about that?
Yeah, thanks. I would just say, yeah, the long-term care market has been long-term care insurance market has been disintegrating for a while. I think it mostly has to do with really poor product design. And as a result, kind of bad risk pools. So something of a downward risk spiral. And the insurers raised their premiums, and you got this, like, just a spiral where nobody was left but those who needed the product the most, and that's not what you want in insurance.
Jamie?
Thank you. I just wanted to mention another idea that came up in our group was that not only primary prevention, but there are some items for secondary or tertiary care, like treatment of substance use disorder and significant severe persistent mental health disorders, which will rapidly decrease the cost of care of the health system, because they are the two deadliest and most costly comorbidities that drive cost. And so addressing those up front may result in additional funds becoming available within a few years, which could be used to scoop in some of the things that might have been on the slightly lower on the priority list. And that doesn't happen if we put those other things high on the priority list. We don't ever get cost savings that help us to do mental health or substance use treatment. So that was the other sort of prioritizing idea that came up for us. I was really interested about the question with long-term care and just that observation. My other observation is, there is currently, it's very simple, well, in parentheses, simple to get vision and dental supplementary plans because they already exist that way. The long-term care, I think as a supplemental plan, we want to question whether that's actually available going forward, but that might be another consideration with sort of a phased approach to some of those benefits, because other ways to cover those may be more accessible.
Thanks, Jamie. Mike?
Just kind of piggybacking off of Dr. Osborne with the immediate cost savings. One of the other paradigms, which is kind of related to that, was, what's going to help long term? That's kind of why we went with prevention. It's why we looked at cost to some degree. It's why we wanted to look at the evidence with what we were determining when we were looking at all this stuff. And so it wasn't just what do we want right away, right now for everybody. It's what's going to help the most people long term. I think that drove some of our decision making in terms of the prioritization for the list.
Thanks, Mike. And then Chair Belanca, we're right on schedule to move on to committee member reflections. I'll just let you take it from here.
Yeah, I just thank you everyone for your really thoughtful comments. It's a lot to process and work through. And I think it's, we weren't expecting that we would all have some sort of unanimous decision about how to approach this. But I think we heard a lot of really good feedback about priorities and how to think this through. Several times people have mentioned the OHP prioritized list, and then the Health Evidence Review Commission has come up before. Are people familiar with those and how they operate currently in the state? I ask because we could decide as a committee, pardon me, hang on. Pardon me. So we could continue to use those as our standard for deciding what benefits are covered. We already have a structure within the state that looks at new treatments and therapies, looks at certain diagnoses, and decides if OHP will cover them. It's a pretty robust structure, and we could decide to say, you know, that if the HERC decides that this is a benefit with enough evidence and enough benefit for our population, that it would be something that would be covered. We imagined something like that existing anyway. The main purpose that we were hoping to get out of this discussion today is, if we're going to change, like if we're going to go with basically a PEB benefit, if we're going to change the PEB benefit in some way, add something onto it or do something different than is currently in PEB, what would we do? What would we enhance? What would we want to prioritize or structure? But in general, covering all those services is obviously our goal, if we could cover all those services for everyone. So I'm wondering if anyone has any reflections based on everything that we've just heard from the small groups of, if we start with a basic PEB structure, what would you enhance it with? What would you say, besides what's already in PEB, besides what's already covered? What would we do on top of PEB to make it work better for people across the state?
And let's start with Betsy.
I mean, I think the list that we were reviewing is a helpful one, and I can't think of any particular coverage that's not included in the PEB plan that I would stake a claim to, except, and my comment that I really wanted to make was just that I assume that the existence of a HERC and or a prioritized list is kind of a bedrock principle to providing coverage this broad. And so I would really, understanding that there's some changes in the wings for that, I can't imagine doing this work without something like that. So yeah.
Eve?
I like the idea of PEB being the plan, and then folks who meet certain income testing receiving the additional services through Medicaid, in our commitment to not reducing anyone's access to resources. When I think PEB, though, I would think about, just as Tony mentioned from our group, the limits of coverage that are in PEB today. I assume there are limits in their coverage on eyeglass costs and limits on how many chiropractic visits or PT visits for certain types of conditions. I think that is embedded with some sort of an ongoing review committee around the evidence. The evidence evolves over time. That evidence should then inform what the benefits are and the limits to the ability to access those benefits, or pre-authorization requirements, for example. All of those pieces will be embedded in PEB. And so if we adopt PEB and say, what we're not going to adopt is the cost sharing, but we are going to adopt all of the basic kind of utilization criteria, I think that might give us a good starting point to get some sort of a ballpark of where we are from a cost perspective, and we can add or decline, add or decrease once we meet with finance.
That's great. Thank you so much. And I think I heard from several groups general agreement with the idea of a tiered plan, meaning if you qualify based on income, that in addition to the PEB-based universal plan, you would also get non-emergency medical transportation, health-related social needs, and long-term care covered. And those would be if you qualified for income. Did anyone object to sort of a two-tiered system in that way, sort of an enhanced plan for those with lower income up and above and beyond the regular plan? It's not ideal, as several people have said. A universal plan should be universal, but in the effort to preserve those extra supports, if anyone objects to that, please raise that now. Okay. And then we had thought before about, relying on a supplementary insurance plan for long-term care for everyone else who doesn't qualify based on income and based on what Anya and Jim were saying, like, that might need to be reevaluated. The task force asked us to think about, a special subcommittee looking at long-term care, and we can look into doing that. I also want to bring up that the task force asked us to consider enhancing behavioral health benefits. I'm not sure what that means or what that looks like, but based on our conversations today, if anyone has ideas about what an enhancement of behavioral health benefits would look like, we know that that's a priority in general for our state. PEB does a pretty good job, as was mentioned, covering inpatient, outpatient services. Access is really a big issue. OHP offers some additional supports like peer recovery mentors and some care coordination services that aren't normally offered in the private insurance system. But in addition to that, are there ways that we can enhance and support mental health and substance use treatment services to sort of make those more available, more accessible? If anyone has ideas on that.
Jim, I know you had your hand up for a minute. You want to go ahead and start?
I'm going to pass for now.
Okay, thank you, Jim. Jamie?
One idea on the enhancement of behavioral supports, it wasn't explicitly stated in coverage that virtual, remote, and long distance services be covered. There's this assumption that only providers licensed in the state are unlimited coverage, but that is not the reality of how behavioral health works in our country and in our world. And in fact, there's really excellent evidence that remote and long distance virtual services can impact mental health, and sometimes even services that don't involve a person, but an app that provides cognitive behavioral therapy support, or an app that provides, so there are some other additional technological things that we might want to include that mental health might cover that maybe don't get covered in typically.
Thank you, Jamie. Peter?
This is my bread and butter. I could talk for an hour, but briefly, Care Oregon recently has been very controversial. So I would say the first thing is to allow mental health associates to provide mental health care. Greater access to group and family care. It's covered, sure, but we could do a better job of coverage and reimbursement. I'll say it 1,000 times, ketamine treatment, as well as ketamine-assisted psychotherapy, equine therapy, wilderness therapy, apps, as mentioned, absolutely telemental health. I mean, if you don't cover that, then I don't know what we're doing. I could keep going, but there are many, I have many ideas.
Thanks, Peter. Gabriel?
Yeah, doubling down on to your question about what else we can be doing for mental health purposes. One of the items in this prioritized list we discussed today was additional support, peer support, care coordination. I think explicitly funding programs like that it can be. I've seen it in my practice. I think they can be a real lever. And to double down on some of the other conversation here, that the potential cost savings on sort of reducing ER visits and other consequences of care by investing in that peer support, that care coordination can be really valuable. The other thing that I hear from my colleagues in behavioral health is just, what are the reimbursement rates? Are we making it attractive as a career option? Is it, for people to go into this sort of work, to train in this sort of work, to attract professionals from near and far?
Thanks, Gabriel. Eve?
Thanks, and I apologize for not being on camera anymore. I'm in transit. But for behavioral health, I think covering case management would be a big
improvement for a high acuity population. I agree on the reimbursement rate side. I think acuity-based reimbursement in behavioral health would help us tremendously in community mental health, where providers are so incentivized to treat lower acuity individuals, and then we have a really hard time in the community behavioral health system treating those with the highest needs. So I think a lot of this is probably in the reimbursement conversation, but case management is something not covered today that would be very useful for certain patients.
Thanks, Eve. Helen, that's all the questions at this time.
I wonder if one of you would be willing to volunteer to draft a proposed enhancement of behavioral health benefits to what's currently offered in PEB. We have to be careful about not convening a quorum outside of a public meeting, but if 2 or 3 of you were interested in getting together to put your ideas together about what an enhanced behavioral health benefit would look like, I think that would be a really valuable contribution. Does anyone want to volunteer to do that? Peter? Yay.
I would be happy to participate. Also, I would also recommend Cheryl Ramirez be a part of that conversation.
Oh yeah, she's automatically roped in. So Peter, who was that was just speaking? Was that Eve?
Yes, it was. Sorry about that.
Okay, so Peter, Eve, Cheryl, is that good? Gabriel, did you want to be in on that too or no? Yeah.
I mean, sort of, but I'm wary of the time.
Oh, okay, no worries, no worries. You're not obligated. I value your input, but if you're not able, that's okay. But Peter, Eve, Cheryl, for sure. Could you 3 put something together in writing about what an enhanced behavioral health benefit might look like? Something that would expand what's already offered on PEB.
Yeah, sure.
And then, awesome, thank you. And then is anyone interested in the long-term care question and so aside from, we'd automatically cover folks who would qualify based on OHP, but in terms of long-term care for folks who don't meet the income requirements for OHP, how we would address long-term care. Is anyone on this group particularly interested in that topic, willing to do some background research and kind of come up with a proposal of how that might be addressed? Basically the start of a little mini task force.
Yeah, I would be interested.
Sorry, I didn't hear who that was.
Tosh.
Tosh, excellent.
Same, Robert.
Tosh and Robert, awesome. Anyone else? That's excellent. If you guys wouldn't mind, and then Katie, help me out. When would it be great if they could get information back to you so that we can have the committee review it at our next meeting? Should we have a little due by date?
Let me look at the calendar and I will definitely reach out to each of those individuals and let them know.
Yay, Katie, thank you. Okay, cool. I think we have anybody else have final thoughts on today's meeting? Anything else we missed or we should do some follow-up on before we move on?
Jamie?
I just wanted to, I'm not sure if you have enough information, Helen, about the prioritization question, or if I heard a recommendation for some sort of perhaps a normative group process that could be conducted in a survey type of way. And normative group process means like, everybody gets 10 dots and you can vote for things to have them move higher or lower on the list.
Right.
If that would help to create a more robust or clear prioritization, that might be something we could consider doing.
Anyone have thoughts on that? So the option is that this committee could sort of get more in detail about, we could come back to you with a clearer list. I apologize, it wasn't super clear today, the things that we were asking you to prioritize, but we could come back with a prioritized list, or a list of like maybe I think 5 or 6 remaining issues, and then have you put them in rank order. We could do that, or we could say that we would trust sort of a bigger statewide process to work on which benefits would be offered based on the evidence behind them, similar to the HERC process and prioritized list. So the choice is a normative process, as Jamie was just describing with this group, versus saying like, we've got a general idea of kind of what things people prioritize from this discussion, and we'll kind of highlight that and then have like a bigger statewide group who's more equipped to review the evidence, kind of rank order them so that this group doesn't have to do that.
Well, thank you, Helen. I think that articulation is very helpful. And, you know, if this group is coming out with enough to get that started, I think that's probably sufficient. I can retract my recommendation.
Well, my suggestion is that it not be, the categories are not wholesale in or out, but rather you might look at each individual category and how you could pare it down if you needed to.
Right. Right. So that gets into a level of detail that I'm not sure
Right.
is
Exactly.
yeah.
Exactly.
Yeah. So, but yeah, I think we heard it, you know, from this group, kind of like their general feelings around. And if we do an enhanced behavioral health benefit and pull out those, you know, make a tiered system, I think we'll get at most of them and then can focus on utilization management. Yeah. Any other thoughts? Okay, I believe we have some public comment. Katie, I think you said there were 3 people for public comment?
Yep, 3 people. I'm happy to call on them if you would like.
Okay, and I would ask folks offering public comment to please limit your comments to 2 minutes or less.
Thank you, Helen. All right, let's go ahead and start with Tom Sinsick.
Unmuting and showing my face. Tom Sinsick, I'm going to go quick. Please refer to my testimony. I think it's important for the conversation that I have today as well as the last time. I want to remind people that the current system is unaffordable and getting worse. We don't know what the upper cost will be. So mention, and it's not equitable. So mentioning that we can't afford it or we don't know what we can afford, this is too early to talk about what we can or can't afford. You need to stay with the high level proposal, let the Revenue and Finance Committee figure this out, and then come back to the next level of discussion you've been talking about. It was great that you mentioned PEB Plus as a starting analysis. You could do a side-by-side with the statutes, ORS 751, do a little check mark to see if you're meeting those things. One of those things is it's time to stop debating any licensed provider. It actually says any licensed or certified provider. And this committee is heavy MD. So please be cautious about how you're thinking about chiropractors, physical therapists, massage therapists, and all that. They give a great benefit to this community and our health. I myself use the physical therapist a lot. It's way better than the neurosurgery that's offered to me for the tens of thousands of dollars. So avoid using the word tier. I'm glad. Drop it from your vocabulary. Enhanced is great. It's very appreciative that came up with as a thing. The HRSN and the transport of health services could be broken out separately into a separate program, not considered in here. That could be a separate application, right? So you get the one thing all together, and that's it. Let's see. Of course, no cost sharing, no cost sharing, no cost sharing. And I think that will cover me well. Thank you very much.
Thanks, Tom.
Wonderful. Mike Huntington.
Yes, can you hear me?
Yep.
Okay. Gonna try to start my video. I don't see a way to start it, so I'll be in the background here. As a retired radiation oncologist from Corvallis, I advocate for major healthcare reform based on my experience with patients delaying care due to costs. The current business model of healthcare is unsustainable, and public service model is necessary for affordability. For decades, we've named fee-for-service as the main cost problem. Attempts to solve this through capitation and value-based payment systems have created new problems, including diversion of time from patient care to administrative tasks, high costs, including administrative, financial, physical, and emotional for providers, degraded patient care, perverse incentives to avoid costly patients or withhold needed services, and then provider burnout and early retirement. I urge the board to adopt a fee-for-time payment system as proposed by Stephen Kemble, MD, and you have his proposal in your written materials. Regarding today's thoughtful discussions on how to ration rationally, hearing, vision, dental, weight loss, medications, and surgeries, skin problems as dramatized on TV ads should all have ceilings of reimbursable cost, starting with hearing. Blue Cross Oregon offered hearing aids for about 6 months before ending it because it would drain the budget. New hearing technology is expected to reduce hearing aid costs from $3,000 to $4,000 down to $200 to $1,000. So we need to wait just a bit. AirPods Pro now offers Look OK, Hear OK for $250 if you have a smartphone. Weight loss drugs and surgical bypass could break the budget, while good primary care and counseling and fasting would not. Tooth implants may look and feel good, but not as affordable as bridges. For all of these services, we can place a ceiling of reimbursement and still provide effective care. Thank you.
Thank you. And Lou is the last one, is that right?
Yes.
Yeah. Can you hear me?
Yeah.
Yeah, Lou Siniger. That's how you pronounce my name. I'm sorry I raised my hand before because I wanted to speak before, anybody voted on anything, but sorry about that. So anyway, I want to stress the idea that everybody is in the same pool. That's why publicly financed healthcare can succeed, because most people are healthy most of the time, okay? So everybody needs to get the same benefit. If we start tiering benefits based on income qualifications, we're going to add administrative costs. And we'll exactly like OHP works now. I mean, I know many people who maintain their income to produce less for our society so that they can stay on OHP. And it's a matter of healthcare survival. That's why they're doing it. Please, if you're going to have a benefit, have the same benefit for everybody. If the benefit only goes so far, then that's it. I can understand that and people can understand it. But what we're trying to do here is get the best health to the most people that we can. You folks are doing a great job. I'm really pleased with your meeting today. You really worked hard. I'm very impressed. But remember, no income qualifications help the majority of people. And non-emergency, you better define it because I got stung by it. Please cover transportation from one medical facility to another. Okay, thank you. I made my 2 minutes.
Yeah, you did. Thanks, Lou. Any final thoughts or anything I'm missing, Katie?
Nope.
Great. Our next meeting, we'll be talking about eligibility. We'll try and get some information out to you in advance to review. Thank you, everyone, for your participation and involvement today. It was a great discussion, and have a good rest of your day.
Thanks all.
Thank you all.